It is Tuesday, June 9, and it's time again for our weekly coronavirus virtual information session. I want to welcome everyone on this call today and looking forward to a very engaged discussion. Next slide, please. So we ask that you keep your mics on mute. If you don't want to be recorded, keep your video off, but otherwise we would love to see you. If you have a question, you can type it in the chat. And if you are concerned about your health, feel free to call us at 588-4340, or you can call the COVID-19 hotline at 1-800-722-5725. If you have difficulty with your sound, you will see here what you can do to test your microphone setup. Next slide, please. Before we begin, it would be good if everyone can just type the county that they are representing in their work or in their personal capacity in the chat. That helps us to keep track of how well we are doing in terms of spreading the information throughout Kentucky and Indiana. So with that, we are going to do another moment of silence and reflection. We believe at the Traeger Institute that we still need this very much. We want us to honor the more than 100,000 people who lost their lives in the US due to the COVID-19. We also want to reflect on the bigger discussions going on in our society today that we're going to engage in today. Specifically, let's reflect in what we need to do to allow our fellow human beings to breathe freely. We will do a 1 minute of silence to reflect on our own breath and how we can help others in our society to breathe as well. So I'm starting it now. We will start our 1 minute of silence. Thank you. Thank you. I appreciate the time for us to be silent. We are very excited today to talk about the disproportionate impact of COVID-19 on African American communities. Before I introduce our guests, Dr. Vicki Hines-Martin and Dr. Faye Jones, I want to ask our medical director, Dr. Furman, to give us her weekly update.
Hi, everybody. I'm Kristen Furman. I'm the medical director of the Traeger Institute, and it's great to have you all with us every week. So there's not a lot to add, but I just want to go over the numbers again and kind of let everybody know, just in case you're not, I know people aren't watching sometimes, and the daily update from the governor as much, but in Jefferson County, there's been 3,104 cases and 169 deaths. And throughout the whole state of Kentucky, there's been 11,476 cases and 472 deaths. In the United States, there's been about 2,001,000 cases with 112,000 deaths, 112,648,000 deaths. Globally, there's been 7,121,000 cases with 406,616 deaths. So, it's still out there. It's still an issue. And I think, people are now kind of getting back into the community, but I think everybody just needs to remember that we still have to practice the hands, face, and space. So hands, wash your hands with soap and water, or alcohol-based sanitizer. When you wash your hands with soap and water, it has to be for 20 seconds. So you really have to count to 20. Wear a mask, don't touch your face, and the space is 6 feet apart. So even at work and other places, we need to keep remembering all that. The governor has changed his daily updates to 4 p.m. on Monday, Tuesday, Wednesday, and Thursday. So you can still get the information through them. And I know the World Health Organization just came out yesterday with something that kind of confused people, saying that maybe you can't get it from asymptomatic people as much as we thought. The issue is that, you know, sometimes it's asymptomatic, but sometimes people are pre-symptomatic, means they're, you know, they don't have symptoms, but then a day or 2, 3 days later, they're going to get the symptoms. And sometimes people's symptoms are mild. So it's like a headache and diarrhea, and they think, or they just have like allergy symptoms, and really it's COVID. So I think the issue is that you don't know. And so that's why you have to wear your mask. You have to stay 6 feet apart. You have to wash your hands. Don't touch your face. Keep doing everything that we've been doing it, and remain vigilant. And I think the World Health Organization is going to come out with some clarifications, because I think when they said, oh, asymptomatic people are not spreading as much, it just made things worse because people got more confused. So really nothing's changed, and just keep doing the same good practices that you've been doing. So yeah, I think we have a lot of good information today. So I think I'll leave it at that and be available for questions at the end if anybody needs anything.
Thank you. The change is what we're facing right now in our society, that we are dealing with racism, we are dealing with a second pandemic on top of the one that we have been talking about for the last few weeks. So that's why we're so excited to have Dr. Jones and Dr. Vicki Hines-Martin here with us today. I'm going to quickly read their bios, and then I'm going to give them each a few minutes to share some of their thoughts, and then we're going to open it up for discussion. We want this to be a lively discussion. Ask your questions, and let's see if we can move towards a little bit more of understanding. So Dr. Jones is the Interim Senior Associate Vice President of Diversity and Equity. She has pursued and developed initiatives at the University of Louisville with a long-term goal of achieving equity by re-envisioning the educational frameworks, developing future research agendas, enriching experiences, including clinical experiences in healthcare, and deepening community involvement for students, staff, faculty, and community partners. Through this strategic, intentionally promoting the integration of diversity initiatives into all the core aspects of the university, the goal is to build a culture of truly valuing the importance of our differences and commonalities. So we're very, very happy to have her with us. And then Dr. Hines-Martin, she is professor in the U of L School of Nursing. She serves as the Assistant Dean in the Office of Community Engagement and Diversity. She's also the Director of Community Outreach in the U of L Health Sciences Office of Diversity and Inclusion. She has been a psych mental health clinical nurse specialist for 34 years. Her area of focus is mental health disparities, culture, social justice, and community engagement. We want to welcome both of you and give you both the opportunity to spend about 10 minutes to share your thoughts with us. Whichever one of you want to go first.
I'll go first. Even though we just talked about it, first off, I want to say thank you for inviting us here, because this is such an important topic, and we're just thrilled to be able to have this discussion. But I do want to go over these numbers again, because it's so important that everyone hears what they are. You know, we exceed over 2 million cases of COVID-19 and more than 112,000 deaths in the US. What is clear to all of us is the disparities that we see. Current data reveals that the disproportionate burden of illness and death among our racially and ethnic minority groups. COVID-19 mortality rate for Black Americans is 2.4 times as high as the rate for whites, and 2.2 times the rate for Asians and Latinos. In Kentucky, there are over 11,400 reported cases with over 470 deaths. In Jefferson County, there's over 3,100 cases with 169 deaths. And a report that happened on June 3rd from the Louisville Metro Department of Health and Wellness reported that when they broke down COVID-19 by racial groups, they confirmed that 57% were white, 32% were Black, 6% Asians, while white non-Hispanic Latino populations in Jefferson County make up 67% of the population. So we see that disparity there. And Black populations accounting for 22% and Hispanic Latino making up only 6%. Asians accounting for 3%. And then with deaths, also that disparity exists. 64% of deaths were white, 30% were Black, 5% Asian. When you break it down by ethnicity, confirmed cases had 16% that were Hispanic Latino, and and the deceased was 3% Hispanic Latino. So we see those disparities in our own community, not just across the nation, but in our own communities. Even when you look at the children with that multi-system inflammatory syndrome as a complication of COVID-19, very small studies from outside the US suggest children with African ancestry are more likely to be affected. So this pandemic dramatically exposed the connection between the social determinants of health and our physical health. It brings into focus what we've known for decades. It's where we live, work, and play determines health outcomes. While only 10% of health is directly affected by clinical care, as a clinician, there are many areas that we need and can impact. Now, Dr. Hines-Martin will talk about the social determinants of health in just a few minutes, but I just want to give an overview of, from a physician point, what issues we need to consider and possible strategies to address. Many of our underrepresented and under-resourced communities report disproportionately high rates of chronic diseases like hypertension, asthma, diabetes, which dramatically affects the outcomes and mortality of COVID-19. Data tells of health disparities are driven by unequal access to health providers, particularly the primary care like internal medicine, pediatrics, family medicine practitioners, and healthcare access. When you look at the data, Black physicians in the US make up only 5% of the total active physicians, and only 10% of nurses identify as Black. We know that having a health professional that looks like you and who can relate to similar experiences can improve overall care and patient outcomes. However, these numbers don't even represent the overall percentage of the US of the 30% people who identify as Black in the US. We need to be growing and supporting our next generation of healthcare professionals beginning in elementary school. Starting with K through 12, let's empower our students in science, technology, engineering, and math, the STEM fields, to better prepare them to enter the healthcare field. Fund pipeline programs to expose students to the many different fields available in the profession. In higher education, we need to incorporate community engagement and policy discussion throughout their education. Augment the professional school curriculum by integrating the impact of structural racism on communities and how this translates in the health disparities that we see today. We can't be afraid to have those real in-depth conversations about race and racism, particularly now, what we're seeing all around us. We talk about Black Lives Matter, but we need to see that it really does matter. Let's demonstrate by providing transparent data for all to see that routinely includes demographics. This has to be the norm, not the exception. Also, it's essential that we examine the concept of implicit bias. Implicit bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. We all have biases, but we know that it can affect medical decision-making related to treatment recommendations. Medical personnel needs to understand and receive training on how bias can lessen the quality of that patient-doctor communication and result in medical mistrust. Medical mistrust is still a very much of a problem in our care, which strains both our confidence and reliance on information that we receive. Building respectful, long-term partnerships with communities are a necessity to counteract this medical mistrust. In this current environment of COVID-19 and in this environment of community unrest, we need to understand how our history and structural racism affects decisions today. For example, consider who is tested and where testing sites are located. How do we educate different communities? Who is involved in the research? How will treatments be distributed? How do we perform telehealth when available resources are so unbalanced? How do we address mental health services to communities that already are at risk for stress secondary to racism? When a vaccine becomes available, how can we ensure that it will be distributed equitably? Additionally, we got to think about employment opportunities, how that limits their insurance choices that can affect treatment plans, and who is able to work from home and who's not. It's interesting to see how the governor's announcement on providing the health insurance for all Black Kentuckians will impact this situation. So that's something that we need to watch very closely. And our housing options also affect our health with the many multi-generation families living together, which can result in an increased risk of exposure. The conditions of the units may also pose a threat to the health in some cases. You know, as a pediatrician, one of my focuses is on the issue of unequal educational opportunities, which is correlated with future health outcomes. But our healthcare in general, we need to be concerned about health literacy. How often do we test for health literacy in our offices? You know, health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information needed to make appropriate health decisions. Nearly a third of adults have low health literacy skills, yet we don't check that in our office when the patient comes in. Transportation is also influences healthcare utilizations. Questions that we could be asking in our office or considering in our office is there a convenient bus route for our patients, residents to our office? Is parking readily available? Is it affordable? What is our late policy, particularly for unforeseen, uncontrollable events? And, you know, the environment also affects of health. Think about air and water quality. The amount of pollution in the air has major impacts on respiratory diseases in our patients. Yet lots of our families live in areas where there is high pollutants. We should also consider our patient's physical environment when we suggest treatment plans. Are there parks or gyms close by? Are there walkable sidewalks or safety concerns that prevent our families from engaging in activities? One of the things that I did when working with some of our pediatric residents, we did home visits, and we took a TARP to get to some of the homes and walked to those homes when we get off the TARP. And the things you may not notice is, okay, our families have to get on the bus, particularly if they have little kids. How are they able to maneuver multiple children, car seats, those things, and still make it someplace on time? When they get off, how far do they have to walk to get to their home? Is it sidewalks, or do they have to walk on the street? Finally, having accessibility to healthy foods should be a given, but in many neighborhoods it's a challenge. But we typically eat healthy, eat lots of fruits and vegetables. They may not be a realistic thing at all times like it is for us. When we disregard the weight of health disparities, not only is the directly affected populations paying the price, but the whole community pays. As I said from the beginning, this pandemic has clearly exposed the disparities in our communities across the nation. The pandemic, not just in COVID-19, but in the structural racism that we face. So if we fail to act now, it would only widen. We have to think both short and long term and push for fundamental, lasting changes. As we move forward, we need to strive for health equity by infusing health in all policies using an equity lens. I want to close with a quote from Dr. King. Of all the forms of inequity, injustice in healthcare is the most shocking and inhumane. We should do better, and with deliberate, transparent, and collaborative partnerships, we can. So I turn it over to Dr. Hines-Martin.
Thank you so much, Dr. Jones. Yes, Vicki.
I wanted to thank Dr. Jones for highlighting some really relevant areas related to healthcare provision. Also to give us an introduction to some of the things that I was going to address and we'll be talking about. But I'm going to look at it from the perspective of everything but healthcare. So we will be, to some degree, talking about the same components, but what does it mean for the daily living and existence of individuals, both pre-COVID and during COVID? So hopefully the repetition won't be too much for you. However, I think the lessons learned from the end of it are somewhat different. First, let's just talk about social determinants of health. As Dr. Jones stated, they are conditions in which we grow, live, work, play, and age. The way that's laid out illustrates the importance of it across the lifespan. You need to know that whatever occurs as you are born and grow into it has a cumulative effect over the course of your lifetime, or according to what the mediators are, or whether they are unrelenting impact on your life. There's been a body of research that highlights that these are important concepts and they've been identified through an evidence-based approach. It's been almost 30 years they've been talking about social determinants of health. They started with a discussion in England. It has expanded to the United States. In fact, the Louisville area was part of one of those discussions when Dr. Troutman was here at the health department. He was part of a documentary, a PBS documentary called Unnatural Causes, Is Inequality Making Us Sick? So it was presented to the public in a comprehensive kind of manner that illustrated that there are cumulative effects that impact not only the quality of life of an individual, their morbidity, as well as their mortality. One of the examples they used in the city of in the Jefferson County in the city of Louisville was discussing people who had different roles within society and how those roles impacted not only their ability to be healthy, but also the choices they had available to them, the control they had over healthy living and the individual behaviors, but also, most importantly, the differences in the length of life if you lived in Eastern Jefferson County versus whether you lived in West Louisville. There was a difference of 12 years of life between those two just geographic areas, even with people who had the same individual behaviors and the same conditions. So there was really stark representation of the differences in how people, what people can expect in terms of their lives based upon where they live. There was also a very clear understanding as a result of the literature that approximately 30 to 60% of the influences on your health are not what most people expect. Most people say, well, if you live a good life, if your individual behaviors are appropriate, then you should be okay. Well, the literature clearly demonstrates that somewhere between 30 and 60% of your health and your health outcomes are related to things that are not underneath your individual control. Based upon how severe your environment is at the upper end. For example, the Navajo Nation currently is having a severe outbreak of COVID. Well, they have poor access to water, poor access to healthcare, poor access to food, and they are in an isolated area in which getting the healthcare they need is not possible. So their individual choices are limited by the severity of their environment. And most people who are under-resourced or who belong to minority populations have more severe contextual issues that they have to contend with, some of which that Dr. Jones has identified for you, that have a distinct impact on their ability to make adjustment and to cope and to have positive outcomes as this additional layer of stress is placed on them. For many of you who may or may not know, the US CDC has a vulnerability index that anybody can go to and take a look at. And what it does is to look at the social determinants within each one of those communities and identifies how readily the populations within those communities could respond to a disaster or to a infectious pandemic. So looking at the data that we ourselves in the US are collecting should give us indicators as to where the stress points should be, where the increased resources should be, and the populations that are most vulnerable. And when you look at those indices, you will notice that most of the high-risk communities are populated by people who either are very low resourced and or minority populations. For people who are not really clear, most of you are, but some of you may not be, who are not really clear as to what the determinants are, some of those have been identified by Dr. Jones, such as transportation, availability of resources such as food. If we look at our city of Louisville and we look at West Louisville, we have very limited food sources other than, fast food sources, those kinds of things within communities. And when those are disrupted, they cause a significant impact on the populations who live in that area, which is a very densely populated area. That's also another factor that needs to be considered. How dense is the population for each community? If you have people who do not own their homes or own small, older homes, those are usually closer together in proximity. If you live in an apartment, you're definitely closer together. Those things put you at higher risk. Lastly, for minority and low-income individuals, there are multiple generations living within one household. That has to be taken into consideration, not only in COVID, but for any type of stressful environment or situation in which those individuals might live. A lot of people have unstable housing or are homeless. Many of our adolescents are at highest risk for homelessness, and a significant portion of those are minority, primarily African American. How are they able to adapt to this particular health crisis? One of the things that I think people forget to include in the social determinants is, which is underlying every single thing that we've talked about and will talk about, is the social norms and attitudes of our society. Who is valued? What is acceptable for a variety of communities? And therefore, what is the impetus to either provide the necessary supports for a variety of communities or the lack of will to provide to different communities? That underlies much of the social determinants that most people identify. Dr. Jones talked about schools and education. We're also talking about public safety, residential segregation. We in Jefferson County do have residential segregation. It is historical, it is unchanged, and it directly influences the resources that are put within those communities. If you are looking at toxic substances, such as bad soil because of brownfields, pollution of air because of industry, I usually tell my students this. Let's look at this in terms of a garden. If you have part of your garden that receives all the sun, great soil, lots of water, and you tend to it, and then you have a part of your garden that's in the shade or is under an eave at your house that never gets the water, and we don't attend to it, and then we expect the garden that's in the shade and under the eave to perform exactly the same way as the garden that gets the sun and gets the tending, people would consider us crazy. But that's what we expect of our communities. We expect that. And we say, you know, every individual has the ability, if they want to make life different. Then we should expect our garden, every garden, regardless of what you put into it, it should perform the same way because of the individuality. That's crazy talk. I want everybody to understand what we're expecting of our minority populations to be just as crazy. I'm not as professional as Dr. Jones, but I'm looking at it from a different perspective entirely. So we're also looking at what does that actually mean for the risk, not what it means for accessing healthcare, but the actual risk for getting it. Well, number one, lower education means that there are limited areas for employment. That means that most of people who are minorities work in essentially as essential workers in low income jobs such as service delivery, industry, agriculture, and if they work in healthcare, they're primarily nursing assistants or LPNs. They work in environments such as nursing homes and acute care settings in which they're more likely to get sick. They're going to be exposed to higher risk individuals. I don't think most people think about the fact that low income means when you're telling people to buy masks and hand sanitizers, that costs money. And if you have low income, where's that money coming from? We've already talked about the housing and multiple families living in housing. We have greater representation in aggregated living, such as detention and incarceration. There's a disparity in incarceration that has been well established, and now that we're in there, we're more likely to be at risk. We've had some discussion of the social determinants of health in relationship to accessing healthcare, all of those things that impact that. When we're looking at indirect impact, we've got all our kids at home in homeschooling. Most people with a low income cannot afford to stay home and homeschool their children. If they have to work something out, they may have a lack of technology, and therefore the children are falling even further behind in terms of the academic performance. We already have a performance gap. When we are looking at, well, what does this mean? Well, it actually means that all COVID did was to highlight what we're already doing inadequately. It just made it harder to ignore. All of the disparities that COVID has highlighted are disparities that play into why we have higher incidences of various conditions and why people are really angry at this point about all the other things that are occurring. We have an opportunity to say how we treat each other by what we support and who we support. We have the opportunity to show that what value we place on people's lives by the context that we allow them to live in. That's a choice we have to make. Right now, it's about COVID, but it's really not about COVID. It's about the situation, how we've made our garden so that COVID can decimate particular populations differently than they do others. That's all I got to say.
Thank you so much, Dr. Vicki Hines-Martin. This was amazing, both of you. You know, I typed a specific question in the chat, and then you all just addressed it so well. I was listening to NPR the other day when they indicated that the fact that African Americans are more affected by COVID-19 has more to do with the jobs that they are in, the frontline jobs, than being sicker. But I was just making the statement that to me in itself is a disparity to put the African Americans at the front line. Do you have any comment on that before we open it up for all the other questions?
No.
I think it speaks for itself. I mean, unfortunately, our populations, our minority populations, have suffered many of these disparities over the years, decades, centuries. And it all relates to structural racism that's been in existence, that a lot of things we don't even realize it's happening. Some of the policies that's there, how that causes and continues to cause these disparities that we are seeing.
Yeah, thank you. Okay, I'm now going to hand it over to Dr. Yankelov to ask the rest of the questions in the chat.
Hello there. So we have several comments and several questions in the chat. Luz indicates that the documentary that you spoke of about unnatural causes was a wonderful documentary. It's still very relevant today. Lauren was asking about an episode of Hidden Brain that had some really interesting thoughts about health disparities that were based on some empirical studies conducted about Black patients seeing Black doctors and the better overall outcomes. Did you guys want to talk about that? I know you've already addressed that as it relates to anything additional. Did either one of you have an opportunity to see that particular? I have not.
I've not seen it. Just that comment as far as people, I mean, sometimes the trust is maybe more there when you have someone that looks like you, that someone you think has gone through the same experiences. So like I said, we only have such a small percentage of physicians and nurses and other healthcare folks that are underrepresented in medicine. So that is something that we need to change. Our healthcare system should look like the community that it's serving.
I think an additional point has to do with, to what degree do you think that there is a congruency between the language and a congruency between the priority in terms of what is asked and how it is asked. Sometimes that is a barrier that can be overcome by the fact that there's a similarity between the service provider and the patient or the client. I find that to be relatively important when I begin the discussion regarding anything that's going to require a behavioral change, more information, teaching, or a situation in which there's potential for negative kinds of a discussion. I was born and raised in Louisville. I was raised in public housing in West Louisville. I left Kentucky and then I came back again. And just the familiarity with what that life is like sometimes helps me to make that better connection.
Mm-hmm.
And I think this is Christian Furman just about that issue. I mean, we need more Black doctors, nurses, healthcare professionals. So what is U of L doing to try to address that? Because Faye, you know, I know it seems like we need to have scholarships or, you know, ways to get, it seems like we lose some good college students to other universities, other medical schools instead of coming to U of L. I know me personally, I was trying to hire an African-American physician for internal medicine, and we lost them to another. At least they stayed in Louisville, thank goodness. But, you know, I don't think U of L is doing that great of a job. I don't know about you, but maybe I'm missing something, Faye. I don't know. Or Vicki too, but.
So you're right. The scholarships is a factor. It's not the only factor, but you know, the folks that's here, how are you making them feel? Do they feel like they're part of the institution? Do they feel like they're part of the group? That is some things that I hear all the time from our students, our residents, our faculty. They don't get the sense of feeling like they belong. So that is something that we have to change in our culture, because if we can't get the folks that's here to feel that way, how can we expect someone to come in? Why would they want to come in? Why would they want to stay? So we have to do a better job of that. And we have to admit that that is an issue.
Yeah,
However we do things. I wanted to have Dr. Jones talk about the SHPEP program, which is to reach out to underrepresented people who are interested in the health careers. We are doing that. We at the School of Nursing have a Black Student Nurses organization that we support. We also have started some initiatives called the Affinities Group, which are groups of students who have a particular perspective or membership that they want to support. In nursing, it's sometimes males, it's sometimes African Americans and other populations. So we are trying to encourage people to have a sense of belonging while they're here at the School of Nursing. But that still does not adequately address the preparedness of our students and making it easy for them to get into healthcare professions. And there's a lot more we can do. For example, to what degree are we putting our resources where our mouth is? Once we decide this is a priority for us, how do we show it in ways that are tangible? And do we ask the people that are underrepresented if that's what they want? I think sometimes you don't even get asked, you know, what you want in terms of the priorities. So those kinds of things are important as well.
Yeah, and mentoring. Mentoring, it's great to have someone that looks like you to mentor, but that's not a prerequisite. How often do we have you volunteered or anyone volunteered to mentor someone, going into the schools and talk to them about the profession and how you would be willing to kind of walk them through or guide them through years of it, not just one time, but take the long time commitment to do this. What Dr. Hines-Martin was talking about with our SHPEPs, the Summer Health Professional Education Program. We've been doing this for 14 years, maybe 13 or 14 years now, but it's 80 students from across the nation. Majority of them are underrepresented in medicine and low-income students that come for the summer. This year's the first time we're doing it virtually, but they're usually here for 6 weeks. But that's an opportunity to meet students, to be a part of that program, to get engaged, because a lot of those students, they will end up in some type of professional school. The question is whether they want to come here or not.
We have more questions in the chat. So we've been talking about disparities for years. How do we go about talking to action? What's the big first step we can take in Louisville? That's from Dr. Joe.
That one's a hard one. That's a very hard one. But, you know, one of the first steps is recognizing, really acknowledging that it does exist and being willing to take that action and put the resources into areas that needs to be put in, identifying these difficult things, but getting people to acknowledge it, because not everybody acknowledges that these things really exist. And that's a shame. So we have to look within ourselves and examine our own biases, our own everything, to make sure that we can make a difference. Be proactive, be out there vocal, think of what you can do to make a difference. Get involved in these programs, that's helping with getting students into the healthcare fields, getting involved with your community. There is an unwritten rule around Louisville, maybe not in some areas, but in Louisville, that we don't want our health professional students to go past 9th Street. I've heard that for years and years. So what kind of message are we saying? And those kind of things has to stop. We have to invest in West Louisville. We talk about it a lot, and there are some pockets of where there is investment, but we have to truly, wholeheartedly invest in West Louisville to help with health disparities here.
I think we need to look at the people who represent us, identify what our priorities are, and to what degree are they compatible with what we think the priorities should be. This is a good year to start looking at that. It's a good year to identify what you want. Many times we didn't even have to think about that. Now we do. So what's the minimum you want, and what's the optimal type of person you would like to support to get what you need and what you want? That requires us to be informed. And that is something I've been preaching to lots and lots of people. Be informed and decide what's valuable to you, what's going to make our community better, and who is best going to represent that.
So there is a book called How to Become an Anti-Racist, but it talks about policy, how we can change policy to make a difference. So our policies is not that you're a racist, but you want to be an anti-racist, and that is working to change policy so it is equitable for all.
Barbara asked in the chat, if you were able to identify the top 5 things that need to occur to change the course of disparities realized in the African American community, what would they be?
Vicki, I'm gonna
you're going to throw that one to me. I knew you were going to.
let you start that one.
First, educational opportunity. And not just at a college level, at whatever level that person feels is suitable to them. As you know, student debt is out the roof, and many of the people who are still paying student debt and don't have jobs that are equal to paying those debts are minority students. That's a start. Identifying what supports are available within community to support health. We've got people who still do not have a routine place to go to get health care, health information, whatever it is they need. If we could work on just those 2 things to start with, I would be overjoyed.
And kind of to add to with the education part, a lot of times folks are screened out of some of these professions because of standardized tests. That's not necessarily a measure of what people can do and how effective they would be. So that's something that we should all look at all levels, is the importance of screening out because of standardized tests.
And lastly, childcare. We can't expect people to be able to function and to grow and to be educated without the ability to to have care for their children, care that they can trust and that will support the development of their children.
And there were comments regarding the analogy that you made regarding the garden. Some folks really appreciated that. Andrea asked, are there organizations that exist where healthcare providers can volunteer their time to give workshops to underserved communities to help increase health literacy in the community?
One of an easy one here, or at anywhere across Kentucky, there's area health education centers. One of their goals is for community education and also to educate our students as well, starting in kindergarten, but the community at large. So area health education center for here in Louisville, it's the Northwest AHEC. And Brenda Fitzgerald is over it, but Kentucky has 8 different centers. So it covers all 120 counties. So that is a wonderful way to be able to do that.
Mm-hmm. I endorse that, and it's Brenda Fitzpatrick, sorry, that is over our Northwest AHEC.
Tom indicates in the chat that the Political Determinants of Health by Daniel Dawes provides some great insights. Barbara also asks, what are your recommendations to those listening today on how to impact change?
Well, what are you doing? That's the question. First, question yourself, what am I already doing? And if it is something that is community-based, political, policy, doesn't matter, keep doing it. If you're not doing any of those things, there's plenty of places for you to do your work. So first start with a self-assessment. What am I doing?
And think about not just what are you doing, but what maybe you might be doing that's hindering the work, hindering that relationship with different communities. So like Dr. Hines-Martin said, take a look at yourself, really examine, do a reflective examination of yourself first.
Lauren indicates in the chat that there's an incredible article called Structural Competency, Theorizing a New Medical Engagement with Stigma and Inequality by Jonathan Metzla and Helena Hansen. And I guess it's an incredible article that should be taught in all medical schools. And it's a different approach than cultural competency to teaching physicians. Instead, it focuses on structural problems and not individual choices.
Now, we have used that article, the basis of that article for 2 things. Our cultural effective care workshop, used that as a base for what we did with that this year, but also in an elective that we did with at the medical school. Very few students, but we used that article as our basis, our framework for teaching. But it should be expanded everywhere. It should be required reading.
Well, I'm fortunate to be in the School of Nursing, in which social determinants is a foundational aspect. Almost all of our clinical experiences delve into what are the structural or societal factors that impact a person's ability to reach a level of wellness that whatever their capacity is. So I think nursing has done a really good job in that area. We utilize it extensively. It is an expectation of our students and our faculty. Now, we can always do better. There's never been a time that you could not do better, but it is clearly on our radar. It is clearly something that we think is important to nursing because we meet people in a variety of settings and where they are. And without understanding the context from which they come, it makes it difficult for us to do our work. So those articles and a lot of others are utilized, and that's primarily my job to incorporate that into our curriculum at all levels of practice.
Avery indicates, as Kentucky moves forward with the governor's effort to achieve universal health insurance for Black Kentuckians, are there examples of states or countries that have overcome and equalized such stark racialized health disparities? And beyond health insurance, what are the key policies that make a difference?
I'm not aware of any place that actually has that all worked I belong to an organization. It's an international organization. And recently I had one of our nursing leaders from the UK come and speak to us about healthcare and their issues in healthcare. Even though they have universal healthcare, they're still having some of the same issues we are. There's variation in service provision from one locale to another, one population to another, and they're struggling with that. If anybody knows of a location that's got that all figured out, please let me know, because apparently most people do not.
So I agree with that. I don't know of any that has. It takes more than just having access to healthcare. We have to be. Shh. So sorry about that. You have to think about what we talked about before: education, job opportunity, wealth building. All of these things are so important and so intertwined. So just looking at one area will not do it. You have to look at the whole.
Mm-hmm. There's a comment regarding yes to mentoring. There's so much evidence suggesting that seeing exemplars who look like you makes a difference. Barbara indicates we should go beyond the walls and exist in these communities. Mona indicates, is our social work programs thinking of how to attract minorities? Since we know that persons have better health outcomes when the person helping them looks like them, very important mental health work starting with our children all the way to our senior adults.
So I know we have some social, and I know we got social work folks on the line. I would hope that will be, and I would assume that is one of their goals too, is try to increase the diversity of the social work training programs. Sorry, Vicki, go ahead.
No, I think there's probably a similar representation in social work as it is in nursing. We are growing in numbers, but there's always areas for improvement in terms of representation. I can't speak to the exact percentage within the school, but I worked on several projects with social work, so I do know that it's not as difficult to find people of different races and ethnicities in social work as it somewhat comparable to nursing, but we all need to do better. We all need to do better.
Mm-hmm. That's right. Let's see, there was a few books that were offered in the chat, how to be an anti-racist and stamped from the beginning. There's a question from Angelica, I think, indicating what are the top 5 policies in place in Louisville that promote racial separation and disparities?
You know, some of these have been from that was put in place so long ago that has caused some of the things that we've seen, like the redlining. That was a policy. And that's why we are now identified as the 4th most segregated city in the US. Redlining, it caused a whole lot. The GI Bill helped with, unfortunately, was one of the things that resulted in this wealth disparity. It was one of the areas that caused some of the wealth disparities that we see today. Vicki, what are some other ones that can be pointed out?
You picked the same 2 that I was going to identify, because they had long-term impact that has not changed. We have not caught up to or overcome the detriment that both of those did. We still have people who do not own their homes. We still have a majority of minority populations, separate sections of town. Those were historically a problem, and they still are a problem. And I don't see a way that we're getting out of it soon, even though we've had revitalization of different neighborhoods. The people who move into those or stay into those neighborhoods are generally the composition, unless they're gentrified, same composition as they were before, except for the people who were displaced and could not come back to their neighborhoods. Where did they go? Where are they living? Because it has been clearly identified that Louisville does not have sufficient housing for people with low income. So when revitalize the community. We make it less dense in terms of the people who live there. We make it a better community. However, all the people who leave that community don't get to come back to that community. We seem to overlook that fact. And they are now permanently displaced from their history, from their community and social connections. And they are living in housing that we have no idea the condition. Are we just putting people at more disadvantage because they cannot afford to go to communities in which the rents are higher? They lived in those communities for a reason. And now those communities can allow or not allow them to come back. That is a disparity that we don't even look at.
There's two comments in the chat regarding, in order to change people need to eat healthy. How does the West End change health when it's a food desert? There's an indication from someone, Lauren. Lauren talks about Cassia Heron that's been working for years on starting a food co-op in West Louisville. Not sure where it is in moving forward, not a solution obviously, but it is a start and a really great model. Did you guys want to talk about that? Or
I know her work, and this would give ownership to the community, not just to a big corporation, but give ownership to the community. And hopefully that as it rises the whole boat. So I don't know where it stands right now for her, but I know she's been, like the person said, she's been working on it for quite some time. And there's a group of folks, and that's happening in more than one area, that folks are thinking about these new ways of doing things to include the community and in wealth. And so we need to be supportive of those ideas.
I think Dr. Karen Krieger, in her community efforts in the Shawnee neighborhood, has worked with the food co-op as well as with HIV prevention and a lot of other things. So there are pockets of people who have been dedicated for years to help to address food deserts as well as other disparities within communities. But they're doing it within the limitations of what they can afford to do. We should be looking at to what degree is the city or our government, however that's defined by you, helping these individuals to do what they need to do. We have to remember the analogy of the garden. We can't expect all the plants to help themselves and be able to do it. There has to be some additional outside help. And it has to be done in a way that is focused on equity, and it is consistent, and it measures the outcomes of what it is they do. So all of those things are occurring. They're just not at a scale that can make a difference overall for that community.
I think we have one question for Dr. Furman. It's from Colby. In the last few days, there's been articles and statements, including from UPMC and the World Health Organization, suggesting that COVID has weakened or its transmission is significantly less widespread than previously observed or expected, saying asymptomatic transmission is rare, yet the rate of positive rates in hospitals is going up significantly in some places in the country. How do we digest news like this?
I think as this pandemic goes on, I think we're starting to figure out it's really individualized, and there are pockets, and I think you have to listen to your local leaders to know what's good for your own community and your own state. States have reopening in different rates, and I think there was a lot of confusion with this World Health Organization say, oh, you can't spread, asymptomatic people don't really spread it that much. But there really aren't that many asymptomatic people. People do have symptoms. It's just that they don't realize they're COVID symptoms. They're very mild symptoms, or they're pre-symptomatic. And then in a couple of days, they're going to get the symptoms. So really, I think we have to continue to be vigilant, because you just never know, if you're going to be the one that spreads it to somebody and spreads it to a population that's not going to be able to survive it, like an older adult population, or a population that has a lot of illnesses that just really won't be able to survive it. So I think we just have to, you know, it's almost at this point, it's an individual decision. Do you go out and do you interact with other people or not? And I think everybody has to be vigilant about knowing who you are potentially spreading it to and what your own situation is and what your own illnesses are. So, you know, when you listen to the national news, it's just every place is different. There's different populations, the urban, the rural. So you just kind of have to take it, the whole context. And it's hard to get all that information in like a 2-second soundbite, you know, so you don't really know the whole story sometimes. So I think when you're listening to these national news, you just have to really listen to the local, the state news to kind of make sure you know what to do in your own situation. It's complicated, and it's complicated because we don't exactly understand this virus 100%. We just don't know everything about this virus.
Okay, well, I want to thank. We have a lot of things said in the chat. We are creating a blog on this whole discussion, so you can access a lot of these wonderful resources online. Thank you for this. Next week, our goal is to talk about the healthcare, having a healthcare panel to talk about what healthcare will look like as we start reopening. So feel free to join us. And I want to really thank our two guests for a very engaging conversation. Thank you so much for your efforts and for what you are doing to work towards anti-racism. Thanks everyone, and we hope to see you again next week.
Thank you all.
Thank you.
Thank you, Vicki and Faye.